Hello. I'll be talking about integrating pediatric palliative care strategies for improving communication. And the overview is that there are key steps that we can take to advance communication skills in palliative care. First, be willing to talk about difficult topics. Second, use communication as an opportunity to build a relationship. And third, promote goal-oriented decision-making throughout care. As we all know, in pediatric oncology, tough conversations occur throughout care. They happen the first day that the clinician meets the child and family at diagnosis. They happen when complications occur, they happen at relapse and during advanced care planning, and they even happen in survivorship when difficult complications arise years down the line. Talking and listening are some of the most important things we do. It's one of our most important interventions. Communication allows for the development of shared knowledge so that what the child and family understands is what we understand. It relieves distress and uncertainty. It builds a therapeutic relationship. And it creates an opportunity for thoughtful decision-making based on the personal values of parents and children. First, if we think about shared knowledge, this is what a lot of us as clinicians think of as the primary purpose of communication, delivering information. And even here, though, when we think of this as something that's so fundamental to communication, we're not always successful. One example is communication about prognosis. We found that over 60% of parents of children with cancer are overly optimistic about the child's prognosis relative to what the doctor thinks. And in the end-of-life setting, parents of children who died of cancer tend to recognize that the child has no realistic chance of cure much later than the physician does. In Joanne Wolf's study, 3.4 months after physicians recognized that fact. But those who understood this earlier had earlier DNR orders, and they used less cancer-directed therapy at the end of life, suggesting that this shared knowledge, this understanding of prognosis, impacts the kinds of decisions that patients make about care. We need to be prepared to have difficult discussions, but these are very hard. We care about our patients, we care about the families, and that's part of what makes it hard. Many clinicians worry that bad news has negative consequences for patients and families, like distress and loss of hope. And as a result, we sometimes avoid these difficult conversations. It's a natural instinct and a compassionate one. We wait for patients or parents to ask for information instead of offering it. We talk in euphemisms, or we sometimes offer overly optimistic information. But in fact, honest communication of bad news can be helpful. And again, coming back to prognosis communication as one example, parents of children with cancer consider communication about prognosis to be very important to them and helpful to decision-making, even when they also find it upsetting. And parents who feel they have too little information about prognosis are actually those most likely to feel upset. In addition, we found that parents who've received more extensive prognostic information are also those who report feeling most hopeful. And this is the case even when the child's prognosis is poor. Prognostic disclosure is also associated with a greater peace of mind and with greater trust in the physician. This seems counterintuitive, the relationship between understanding prognosis or hearing about prognosis and feeling hopeful. And we don't really know why this is the case, but the literature suggests some possibilities. First, uncertainty is distressing. It makes us fear the worst. And honest communication can relieve that uncertainty and relieve that distress. In other words, parents and children are worried about these issues whether or not we address them. So if we address them, we bring it out into the open, and we can help manage those fears and also correct misconceptions. When we communicate about difficult subjects, we also affirm that we'll be with the parent and the child through tough times. We're not going to shy away from these things. We're not going to avoid these things. We're going to be there. And parents who know what's ahead feel more prepared to be there for their children, which ultimately is one of the core roles of parenting. Ultimately, promoting false hope is not a goal of medicine. Being with parents, patients, and families through hard times is. And honest, caring communication of bad news is one of the ways we can be there through these tough times. Another goal of communication is developing relationships. These things all go together. Developing relationships starts at diagnosis and it continues throughout care. Children and families need to know that their caregiver cares about them, can be trusted, respects and listens to them, and will continue to be there as the illness evolves. There's no prescribed path, but we can foster a relationship by engaging the child and family in teaching us who they are as people. And this is a place where our most important role is probably listening, especially with children who may present these occasional opportunities to important conversations, and then the door closes and that opportunity is passed on. And so by listening, we teach children and parents that their words have meaning. Questions have dual roles. They allow the child and parents to express themselves, and they also give us information that helps in providing the best possible care. One way to do that is to learn about hopes and fears. And this is among the ways that we can get to know our patients. We can explore what's important to them in their care, and this sets the stage for formulating goals of care. Several people, all of whom are in the room, have recommended different ways to talk about these things. Joanne Wolfe and her colleagues suggests questions like, as you think about your future, what's most important to you? What are you most worried about? Chris Feutner talks about hope. What are you hoping for? And then he expands on that. What else are you hoping for? And what else are you hoping for? Knowing that people have many hopes, and this is an opportunity to find out that full spectrum. Pam Hines and colleagues have suggested asking parents what it means to be a good parent. What does it mean to you to be a good parent in this situation? And I'll come back to this a little bit later. And then Lori Weiner, as she mentioned, for adolescents and young adults, also has some specific suggestions. She suggests that we assess readiness for conversations. This is another way of looking for that window of opportunity, and engage the family in the decision to talk with the patient. And focus on topics of importance to young people: how I want to be treated, who I want to make decisions for me if I cannot, and how I want to be remembered. And then we use this information to help patients and families make decisions about care. When a child's cancer is incurable, I think many of us are relatively, we fall back on goal-oriented decision-making as an important principle, an important way to make decisions about care. But we should be thinking about this throughout the child's illness. That can help with the transition to palliation when the time comes. Again, getting to Joanne's work at diagnosis, the primary goal is usually cure, but even during that time, parents usually consider palliation a priority. And conversely, when standard therapy has failed, parents typically want to continue to incorporate both cancer-directed and symptom-directed therapy into care plans. Making goals a part of decision-making from the time of diagnosis can help us learn what matters to the parent and the child, and care can be framed in the context of these goals. Ideally, we make recommendations about care, as Lori just mentioned, rather than relying on the parent to make decisions on their own. But we have to be careful to make sure that parent perspectives and child perspectives are heard and understood while we make those recommendations. A recent study found that clinicians often reach a decision about the preferred direction of care and then present it to parents, but parents often wish for a more active role and can take on that active role. And similarly, parents often seek options beyond those offered by the oncologist. So they have lots of thoughts of their own that we need to listen to before we get ready to make those recommendations. Getting back to Pam Hines' work, one of the ways that we can try to understand parent values is to understand what it means to be a good parent. Parent beliefs about what it means to be a good parent of a seriously ill child influences their decision making. And parents have lots of different priorities: ensuring the child feels loved, guarding the child's health, serving as an advocate for the child, and promoting spiritual well-being, among other priorities. Understanding those beliefs can help guide exploration of values and recommendations about care. It's the start of a conversation about where care can go. And similarly, Chris Feutner has talked about heuristics for parental decision-making. Parents employ heuristics or rules of thumb to encapsulate their views, to express their views to others, and to use as a decision-making compass. Some examples are: I want my child to have quality of life, I want the best for my child, everything happens for a reason. And we as clinicians can listen for these phrases and explore them, and in doing so, partner with parents in supporting these goals. As I mentioned before, and others have mentioned, starting conversations early is helpful. These conversations are appropriate for all children and their families, regardless of the phase of illness. They address fears about the future. They help us learn what's important to the child and family, and they allow the clinician, child, and family to know one another as people. Over time, returning to these conversations reassures children and their parents that they matter, that they're known, and that we'll do everything we can to uphold their wishes. So I'll return to what I mentioned at the beginning. What can we do to advance communication in palliative care? The priorities I mentioned are clinical priorities. We can be willing to talk about difficult topics. We can use communication as an opportunity to build a relationship, and we can promote goal-oriented decision-making throughout care. At the same time, we need to work to move the field forward. And one of the areas, and Joanne will talk about this next, but just to briefly touch on it, one of the areas is in research. There's a lot that we don't know about how to have these conversations. We know it's important that the conversations occur and that they're very meaningful to patients and families. But we really don't know what the most effective communication techniques are and what the communication techniques are that lead to improvement in patient and family outcomes. That's still a big hole in the literature. We also don't know how we can best help patients and families make decisions for care that are centered on their personal values, and how we can most effectively train clinicians, both younger and more established clinicians, in these techniques. Along with that comes a need for resources, not just resources to allow for the research, but also how do we support the time and effort of clinicians to engage in these encounters. These are time-intensive conversations, and they're longitudinal. They don't just take place once, they take place over and over again over the span of our relationship with that child and family. And how do we support the training programs needed to equip clinicians with the needed skills? So now I'll turn it over to Joanne to expand on these things. Thank you.